Hey podcast listeners, Fawaz Al-Mufti here from Westchester Medical Center, New York Medical College, and I'm your host on the Neurocritical Care Society podcast. So any patient admitted to the intensive care unit with acute hypoxic respiratory failure often receives supplemental oxygen, with a high fraction of inspired oxygen, FiO2, resulting in high partial pressure of arterial oxygen, PaO2. And although we love oxygen, supraphysiologic levels are believed to be harmful. My oxygen dilemma has always been that without it, cells die. With too much, they die even faster. Due to limited data, clinical guidelines give no recommendations for oxygenation targets. In some trials, such therapy has been associated with increased mortality. Unfortunately, the data is all over the place. Some studies and surveys amongst intensivists favor lower oxygenation targets, suggesting it was feasible without evident harm. However, the liberal oxygenation versus conservative oxygenation in ARDS, the LOCOS-2 trial, was stopped prematurely because of higher frequency of mesenteric ischemia and higher 90-day mortality in the lower oxygenation group than in the higher oxygenation group. Today, you will hear Dr. Jon Rosenberg discuss with Dr. Schjørring, on behalf of his co-authors, their article entitled Lower or Higher Oxygenation Targets for Acute Hypoxic Respiratory Failure, published in the New England Journal of Medicine last April 2021. I hope you enjoy this episode.
Hello all, my name is Jon Rosenberg. I am a neurointensivist at Westchester Medical Center. I'm here with Dr. Schjørring to discuss the recent trial, Lower or Higher Oxygen Targets for Acute Hypoxemic Respiratory Failure, also known as the HOT ICU trial, which is the largest and most comprehensive RCT to date, examining outcomes of different oxygen targets in critically ill patients. My interest in oxygen targets and optimizing oxygen targets in the ICU started with my initial interactions with intensivists who came from a pulmonary and anesthesia background when I was a medical student and medicine intern. And then this interest really resurfaced 2 years ago during the first wave of the COVID-19 pandemic in New York City, where the ICU I was a part of, we took care of exclusively patients suffering from COVID-19, many of whom had ARDS, critical illness. So I was very much been following the landscape and enjoyed the study. Dr. Schjørring, why don't we begin with discussing the inspiration for the study and maybe summarizing the landscape of the literature prior to the HOT ICU trial?
Yeah, thank you. And first of all, thank you for having me on the NCS podcast. I'm very happy to be invited. When we planned the HOT ICU trial, the literature on oxygenation targets were very sparse. There were few randomized controlled trials, a pilot study from Australia and New Zealand, and some before and after trials or studies, which meant that we didn't really have any solid evidence on the subject, and therefore my colleague, my professor, Bodil Steen Rasmussen, and our partners from the Center for Research in Intensive Care, they planned to conduct a large randomized controlled trial, a pragmatic trial with wide inclusion criteria to establish some general evidence on higher versus lower oxygenation targets in a general hypoxemic ICU population. But before we started, the evidence was, as I said, very sparse. We had a pilot study, and then right when we were designing our trial, the first larger RCT came out from Italy by Girardis and colleagues, which was actually published right when we were planning this trial. And it had quite an impact on our power calculations, actually, because they found a markedly reduced mortality with a more conservative oxygenation strategy as compared to their Italian standards, which were by Scandinavian practices quite liberal, very liberal, actually. But that meant that the effect estimate were actually increased in our power calculations. But that was the first trial, and this trial had some issues as it was a trial that was stopped at an unplanned interim analysis due to an earthquake in the city of Moderna, where they conducted the trial. However, this was the best evidence at the time, and since then, several studies. First of all, the ICU ROX trial came out, and the LOCO 2 trial in ARDS patients from France, and then our hot ICU trial currently being the largest trial. But the fact is that since we really had no solid evidence in any subpopulations in the ICU, we wanted to conduct a pragmatic trial with as wide inclusion criteria to include more or less every hypoxemic patients in which there was no definitive evidence. So it's in that way extremely pragmatic.
And this was the oxygen ICU trial, correct?
Yeah,
the
exactly.
Italian trial.
By Generalizability,
Okay.
yeah.
And then that study only had about 480 patients compared to your study, which had over 2,000 patients.
Yeah. Can
you give us a little bit of an introduction into the trial design, inclusion criteria, primary, secondary outcomes, and maybe discuss a little bit why the oxygen targets of a PaO2 of 60 and 90 were selected for the conservative and then the kind of standard oxygen therapy?
Yeah, well, first, the inclusion criteria. As I said, we wanted it to be as pragmatic as possible, so we had very few inclusion criteria. We had to be adult, of course, since this is not a children's study, and then you needed to be admitted to the ICU, and we want to randomize patients as soon as possible after ICU admission to be able to target the oxygenation and not have the effects of either higher or low oxygenation targets before randomization. And we set that cutoff to 12 hours so that clinicians had 12 hours to include patients. And this was actually quite longer time than we initially wanted, but to make it possible and pragmatic and to enable to include patients in as many centers as we had, the 12 hours was deemed acceptable. And then we wanted patients to be hypoxemic, but rather than making a PaO2 FiO2 ratio or a PaO2 level under which patients should be to be deemed hypoxemic, we again chose a pragmatic approach where the level of oxygen supplementation defined the patient to be hypoxemic enough, meaning that patients should receive either an FiO2 of 0.5 in a closed system, being invasive mechanical ventilation or non-invasive ventilation or continuous positive airway pressure, or 10 liters of oxygen, pure oxygen in an open system, regardless of any concomitant flow of atmospheric air. And these were primarily high flow system patients in high flow system that were included here, but anyone receiving more than 10 liters of oxygen in the ICU above 18 years of age were includable. And because we chose invasive targets of arterial partial pressure of oxygen, we also required the patients to have an arterial line in place for blood gas sampling. And as far as I know, we conduct a lot of ABGs in Denmark and Scandinavia and in Europe in general, as compared to what you do in most of the United States, I believe. So for us, this was quite natural to select a PaO2 target because that's what we usually do. And also, we evaluated that a PaO2 target would increase the separation between groups because we believe it's more precisely to titrate after than the SpO2 or SaO2. And then the exclusion criteria in the trial are generally rarities, meaning that we have very few large groups of patients that are excluded again because we wanted to have all hypoxemic patients included. So only conditions like carbon monoxide poisoning or paraquat poisoning, or of course the ethical problems with patients being pregnant and stuff like that made us exclude patients. And then patients receiving home oxygen treatment because we believe they would have possibly a whole lot of reaction towards oxygen titration. So our exclusion criteria are actually very, very few, except for the 12-hour limit.
And to echo what you said, I thought one of the impressive parts about this trial was it was a large multicenter trial across 35 ICUs across Europe with almost 3,000 patients with broad inclusion criteria. You tried to be as inclusive as possible. So I thought that was something that struck out to me compared to prior trials. In your study, you were powered to detect a 5% mortality difference, assuming a death rate of 25% at 90 days. So 25% mortality for a critical population seems a little optimistic, maybe based on prior trials. Looking back on this, do you think the study was adequately powered?
Well, one could discuss whether the power was adequate. I mean, the thing is that when we designed it, we didn't really know how hypoxemic these patients would be who were actually included, because we had this pragmatic FiO2 criteria, meaning that they could be very hypoxemic or they could be less hypoxemic. And this would actually depend on how restrictive the general ICU physicians were in our including sites, because if they were very, very restrictive with oxygen supplementation, we would have more severely hypoxemic and thus more critically ill patients included. And I think that was the case, that because over the last 10 years, but especially the last 4 or 5 years, most of ICU physicians have become more and more restrictive with oxygen supplementation, meaning that our population were, as you can see in the baseline PF ratios, in fact, very hypoxemic, the equivalent of moderate to severe ARDS, in fact. And this, of course, made the estimations of mortality in the power analysis off, because we estimated 25% mortality, which is taken from a combination of previous trials and then the Danish intensive care database, which includes all Danish patients in ICUs. And they have a 30-day mortality of 20, and then we made it a little bit higher because it should be 90 days. And then, of course, we were aware that most critically ill studies in general, trials in general, they tend to overestimate the mortality, because that will make the relative risk reduction easier to obtain. So whether a higher mortality actually increases or decreases power depends on whether you believe that this higher mortality is possibly attributable to the intervention you apply, which in this case is oxygen. And now afterwards, we can see that is probably not, because we found absolutely no difference. But we did not know that up ahead. And the power calculations, I mean, we might as well have been overpowered than underpowered. But of course, the effect estimate was definitely overestimated. But that was based on on a meta-analysis of the current literature at the time. So that's probably due to previous trials and either different strategies or random fluctuations in the trial that went before the Hot ICU and ICU ROX trials.
That makes sense. And we'll circle back to a few of those points that you made when we discussed the results about how your population in general was a pretty sick population compared to prior trials. Yeah. So can you summarize the key results of your paper, and then we'll kind of discuss how?
If I go through the results quite quickly, we randomized 2,928 patients, and most of these were followed up. We had a loss of only 40 patients, meaning that we have 2,888 patients in the primary analysis of the primary outcome, and there were, in our opinion, at least, adequate target separation. I think it's one of the best separations in compared to other trials on the subject, meaning that the low oxygenation group had PO2 levels around 70 millimeters of mercury, and the high oxygenation group had PO2 levels around 93. So the lower group was perhaps a bit over. We can discuss that later if that's in fact the case. And the higher group were more or less spot on the oxygenation targets. But anyway, adequately separated, and with the interquartile ranges being clearly separated between the groups. And the outcomes were overall very neutral, meaning that the mortality rates were around 42% in each group, which was the primary outcome, and the percentage of days alive without life support and the percentage of days alive and out of hospital were identical, and so were patients with one or more serious adverse events defined as shock or ischemic events, being myocardial ischemia, intestinal ischemia, or ischemic stroke in the ICU. And all of these outcomes at 90 days were more or less equal between groups. Yeah, so that was the fast through results.
And Basically, to summarize, the study showed that the study showed that a conservative oxygen strategy targeting a PaO2 of 60 versus targeting a PaO2 of 90 had no difference in outcome in 90-day mortality nor secondary outcomes. Your patients were relatively sick, as you mentioned, as we touched on earlier. The average age was 70. About 20% of patients in both groups had COPD, so they may be accustomed to a lower oxygen target, and about I think 12 to 13% actually had ARDS, as you touched about earlier. The initial P to F was quite low, and they were treated. 12 to 13 were treated for ARDS.
But we must remember that the baseline, the ARDS at baseline is actually at baseline, meaning that these are randomized within 12 hours from ICU admission. So quite a few of these patients would logically develop ARDS at a later point during the ICU admission. So although ARDS were not clear at baseline, there's a lot of patients in the trial may be actually ARDS patients. However, we do not know this for certain, but likely that's the case because of the rather significant hypoxemia patients actually have. Although this is definitely not a ARDS trial as such. Yeah.
And the mortality was 42% around in both groups, which is higher than prior trials. I guess, how do you think that affects the generalizability of the trial, and kind of to lead that? And how do you think that affects the generalizability? And then where do you see future directions then for oxygenation targets?
Well, I would say of course you can only apply these results to a similar population, meaning that you need a rather critically ill patient population to apply and to assume that our findings are similar. However, when you look at trials in less ill patient populations like the ICU ROX trial, this trial, which is the second largest to date on the subject, also has neutral results. So probably these results are applicable in a rather large patient population, I would say. Of course, there are some patient populations that we had fewer inclusions of than we expected, or maybe not than we expected, but at least this was the case, like patients with any cerebral trauma like stroke or traumatic brain injury were very underrepresented in the trial, unfortunately. But that was just how it worked, because I think neurocritical care departments were very reluctant to join a trial that targeted 60 millimeters of mercury. Perhaps in the future, but we'll see.
Mm-hmm. Agreed. I think the trial, this trial and the ICU ROX trial definitely show for your average kind of medical ICU, cardiac ICU patients that a conservative oxygen therapy is quite valid to target. And there was only 1% of the trial of the patients had a traumatic brain injury, but about 10% had cardiac arrest.
Yeah.
And then in your supplementary analysis, you did the subgroup analysis and found no difference in outcomes again within these subgroups of TBI and post cardiac arrest. One question I had for our listeners as well is, do you know by any chance that any of these patients had intracranial monitors placed?
We don't know.
No.
Because we don't have data on this, and I mean, we had I believe we have 12 or something like that in one of the groups with traumatic brain injury. 14 in one of the groups and 8 in the other. So 22 patients with traumatic brain injury in the entire trial. So it's a very, very marginal subpopulation, and we don't know much about this subpopulation. Not the neurocritical care part of it, unfortunately.
I'm particularly interested in the lower oxygen strategy and in the post cardiac arrest patients, and I know that there are some trials coming out. For you, where do you see the future directions of oxygen targets in critically ill patients?
Well, I think our trial found a neutral result. However, it does not preclude injury in a relevant, clinically relevant degree by either a high or low oxygenation target, because our confidence intervals are still rather large as compared to what a relevant finding would be, because so many patients in the ICUs worldwide receive supplemental oxygen. So even 1% of relative risk reduction or absolute risk reduction is definitely worth identifying, and would still have an enormous impact in ICUs in general. So therefore, I think larger studies as the current MegaRox trial, which is ongoing in Australia and New Zealand, and the similar UK ROX trial, which have, I believe, 16,000 and 40,000, something like that, for the MegaRox trial. So these are very, very large trials, and I know the MegaRox trials has different subpopulations, the platform trial with subpopulations, so that they will have adequate power also for patients resuscitated from cardiac arrest, where we found rather different results actually than the ICU ROX trial, as we found no difference in the subpopulation, whereas they found an indication of harm from higher oxygenation targets, but of course only explorative in the subpopulation. Yeah, so I think larger trials are definitely necessary, and yeah, they are luckily on their way. So we'll see.
Dr. Schjørring, is there anything else that you'd like to touch on? Any other messages or topics you'd like to touch on?
Perhaps I think now with the ongoing COVID-19 pandemic, it may be relevant to mention that although this is a neutral study, I think it may have some relevance for the pandemic, especially in areas where oxygen supplies are scarce, and where it's actually a problem to get enough oxygen to the ICU when there's definitely too many patients admitted. And here it may be nice for physicians to know that if they actually do target low oxygenation levels, they probably do not cause a lot of harm by doing so. And so that may be a good idea. And we actually just recently published a subpopulation of the COVID-19 patients that were included in the hot ICU trial, which overall did not find any significant differences, but may indicate reduced days, increased days alive without life support in the low oxygenation group. So with that in mind, even though it's only 110 patients in the subpopulation, it might give some insurance that you don't harm patients by targeting low oxygenation levels if you are in a oxygen restricted area or oxygen supplies are low. Yeah.
Agreed. I think that's a very kind of interesting point, that one way to look at these trials is there's no difference in outcome. So it was a negative trial. And the other way is that a lower oxygen target is just as, maybe for certain patients, maybe just as good as the standard oxygen target, which allows us then to utilize resources. And then as we have trials with more power to look at the subpopulations, we can best personalize our oxygenation targets.
Yeah, and also I think a lot of physicians tend to go with their gut feeling and tend to do what they think is best. So in that way, a neutral trial is actually kind of a blessing, because then you can go with your gut feeling, and at least knowing that there's not hardcore evidence that you harm the patient. So you can, if you have some specific reason to target 90 in one patient, but you have another reason to target 60 in a different patient, you can do that and still sleep well at night, because you definitely will not increase the mortality dramatically by doing so.
The glass is half full, not half empty.
Oh, and just one final comment. Conducting a large multi-center trial like the hot ICU trial requires a lot of work from a lot of people, and especially the national and local investigators have investigated great efforts and time in making the trial possible. And also I would like to specifically acknowledge our Professor Bolsten Rasmussen, who was the initiator of the trial, as well as sponsoring principal investigators, and my colleague, Dr. Thomas Lass Klitgaard, who together with me coordinated the trial.
Dr. Schjørring, I continue to be in awe of all the great trials that come out of Denmark and come out of it's quite impressive. Just you're able to kind of cohort so many multi-center trials. It's quite impressive. In critical care, so many multi-center trials in critical care. So
we have some very, very good good physicians who are driving it, and a good network between ICUs both in Denmark and the rest of the Scandinavia and the rest of the European Union. So I think there are a few more trials on the way. So it goes very well, I believe, which is nice. And also we have a national patient registry system that is quite good as compared to the rest of the world, because we can identify patients by the personal security number, which is general, meaning that our loss to follow up is always very, very low, because it's only patients who actually refuse consent that have to be excluded. We don't really lose anyone to follow up. As long as we have the social security number, we will always find their 90-day mortality. So that's quite a blessing when doing research in the Scandinavian countries, at least. And most of our patients were from the Scandinavian countries and Finland as well.
All right. Thank you so much.
Thank you for having me. It was a pleasure being in your podcast.
While there exists a legal provision for brain death, institutional protocols for diagnosis are not universal and are often absent, as no specific criteria for diagnosis is mandated. Available in both English and Spanish, the Brain Death Determination course, presented by the Neurocritical Care Society and endorsed by the American Academy of Neurology, aims to standardize the process of brain death diagnosis. This certification course, accredited for 2 hours of continuing education, highlights the necessary steps that must be taken, reviews the various exam methods, discusses proper documentation, outlines appropriate communication, and describes common pitfalls and barriers that may arise during the exam process in order to help clinicians, allowed by their local laws, to perform brain death determination. Visit www.neurocriticalcare.org/braindeath to learn more about the certification and use promo code PODCAST for an extra 10% off the purchase of this course.
Thanks for listening to the NCS podcast. The NCS podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. Our production staff includes Tarek El-Maghribi, Andrew Barishmet, Leonid Groisman, Atul Kalanuria, Lauren Kaufman, Cassie Cronfield, Holly Ledyard, Lindsay Marchetti, Alexander Reynolds, Lucia Rivera-Lara, Jon Rosenberg, Jason Siegel, Zachary Threkold, Teddy Yoon, and Chris Zaman. Our administrative staff and senior producer is Bronnie Rousseau. Music by Mohan Kadapali from the University of Miami Division of Neurocritical Care. If you like our show and want to learn more about us, check us out on Twitter, Facebook, or LinkedIn. The NCS podcast is available on NCS On Demand, iTunes, and wherever you get your podcasts. I'm Fawaz Al-Mufti, and thanks for listening.